to welcome Summer. Summer is the Senior Advisor for Behavioral Health Transformation at the Colorado Department of Human Services. And we've invited her here today to share an overview of the plan to establish this behavioral health administration and how it'll impact the behavioral health system, especially data systems. So at this point, Summer, I will turn it over to you.
Great. Good morning, everybody, and thanks so much for having me. I'm excited to be here and give you an update on the Behavioral Health Administration and have some conversations around data and all that kind of good stuff. So I'm going to kind of spend some time going through the presentation. I heard as I jumped in that there's it sounds like there's varying knowledge of the Behavioral Health Administration and what it is and what it's going to do and where we're going with it. So I'm going to go over some basics and then go through some of the expectations for the Behavioral Health Administration, and then really want to just make sure that we have time to open it up for questions. So I will try to go through it as quickly as possible, but not too fast so that I kind of go, you can't keep up with me. But I do have a tendency to talk fast. Okay, so one thing that I will just share before going any further is that what I'm going to share with you today is just an update as of November 2021. And I share that because for a couple of different reasons. One is that we are continuing to listen to stakeholder feedback and try to take that into consideration. And so, to some degree, the Behavioral Health Administration is changing. I mean, not a lot right now on a daily basis, but I would just say we're trying to be thoughtful of the feedback that we are getting. The Behavioral Health Administration and its budget request is still making its way through both the governor's office and, of course, it'll be ultimately approved by the legislature. So that could have some changes on things as well. So I wanted to share all that just so everybody knows that what you're hearing today is not set in stone, and it could change. I think it'll probably change slightly, but I don't expect any big changes. The other thing that I will just share with this group is that the Behavioral Health Administration, its name is administrative in nature. So that means actually that it's kind of putting the infrastructure in place for the behavioral health system in Colorado that we don't currently have in place. And it's more of a long-term systemic change. It's not necessarily focused on kind of short-term changes that everyday Coloradans will experience right now. We also know that there's a huge need right now, and I know that the Office of Behavioral Health is working really hard to look at what are some things that can be done immediately to help Coloradans. The Behavioral Health Transformational Task Force is looking at their $450 million investment opportunities to see what can be done here in the short term to kind of help address some of the crisis needs that we're seeing. So I wanted to share all that too, because while you're not going to see a lot around kind of the person with lived experience or their family members in this presentation and directly in the Behavioral Health Administration, it is the North Star that we continue to turn back to. So every time that we are grappling with a decision, as we're looking at options for consideration around the functions of the Behavioral Health Administration, it always comes back to what does this mean? What's going to be best for Coloradans who are in need of services? And so I think it's just important to hear, especially because the Behavioral Health Administration is just so administrative in nature. Okay, so for those of you who may not be familiar with the Behavioral Health Administration or not living and breathing it every single day, I'll spend a little bit of background talking about how we got to where we are. And I'll start just back in 2.5 years ago, in the spring of 2019, Governor Polis established the Behavioral Health Task Force to really look at and evaluate the current behavioral health system in Colorado. And he was looking for recommendations on what it's going to take to have a behavioral health system in Colorado that works for everyone. So we have a system right now that works for some Coloradans. It doesn't work for everyone. And Governor Polis really wanted to hear all of those different recommendations. The task force and its subcommittees had around 150 people who participated from across Colorado, very diverse representation in every definition of the word that you would, in the way that you would define diverse. the Behavioral Health Task Force put forth recommendations to Governor Polis in September of 2020. He immediately endorsed them, and I would say within a week we were working on our implementation plan and looking at how are we going to get some of those recommendations implemented as fast as possible. One of the biggest priorities coming out of the Behavioral Health Task Force was to create a behavioral health administration. So I'll talk a little bit more about what that means exactly here in a minute, because the concept has changed quite a bit since we were just starting to kind of begin the planning process a year ago. One of the things that we've done, well, we've done a lot of things between January and October of this year, one of which was to do a deep dive analysis of looking at all of the behavioral health programs and funding streams across state agencies. We have identified there's about $1.5 billion in public behavioral health dollars across 14 different state agencies and the judicial branch, and it's over 120 different types of programs. So I think no surprise to anyone who's in this meeting, it's a very convoluted and complex system that we currently have, with every state agency kind of defining data differently, collecting data differently, having different reporting requirements, and so forth. We also spent a lot of time doing 3 big rounds of stakeholder engagement from January of this year through October. The first round of stakeholder engagement was really just kind of getting a sense of what stakeholders wanted to see in the Behavioral Health Administration and what it meant to them. The second round of stakeholder engagement was really focused on kind of reviewing some of the models under consideration for the Behavioral Health Administration. And then the third round of stakeholdering was really around kind of sharing the model that I'm going to share with you all today. And again, continuing to solicit feedback, hear suggestions and thoughts, understand where we might have missed the mark, where we need to have more conversations, and so forth. So right now we did submit a plan to the General Assembly earlier this month on November 1st that kind of lays out the phased approach to getting the Behavioral Health Administration up and running. So I'll talk a little bit about that today so you can have some expectations. We do anticipate that there will be legislation in the 2022 session around the Behavioral Health Administration and its responsibilities and kind of its functions. And then by statute, we are charged with establishing the Behavioral Health Administration by July 1st, 2022, which is really right around the corner, is what it feels like. And what I will always say to everyone is that we will be partially functional on July 1st, 2022. Because we're taking a phased approach, we certainly will not be 100% operational, and I don't expect that we will be operational 100% until 2024. So that just gives everyone a little bit of background. I mentioned the stakeholder engagement that we've done just since January of this year. This slide just gives you a sense of kind of where we've heard from people and where we've gone across the state to hear some of that feedback. And then just the different types of stakeholders who were engaged in this process, who I think really gave us some candid feedback along the way and was really, really helpful in shaping the Behavioral Health Administration and what you're going to hear today. And let me see, I see a question around in the chat box. Does the $1.5 billion include both state and federal funding? It's actually just, it is public dollars that does include federal and state. So that does include Medicaid, both at the federal level and the state level as well. So all public behavioral health dollars. All right, so let's talk about the BHA, especially for those of you who are not familiar with it. We think about the Behavioral Health Administration as kind of the lead entity for behavioral health in the state of Colorado. It will actually be the first time that we will have a comprehensive approach to identifying and understanding the behavioral health needs across our state, and also developing solutions and working collectively to make sure that we are addressing all of those challenges across the state. It's really meant to streamline our system, make it more efficient, make it more effective, and also really make sure that we are including the voice of everyday Coloradans. One of the things that we heard loud and clear from all of our stakeholder engagement the last 2.5 years is that we have to be more thoughtful and purposeful about including people with lived experience and their family members in the system, right? And so we're working really hard right now to ensure that we are helping, or we're asking people with lived experience and their family members to help us design the system so that we actually have a system here in Colorado that works for people who are trying to use it. So we've heard that loud and clear. We also know that equity is critical and a cornerstone for our work in the Behavioral Health Administration, and that we really need to be thoughtful about how we're going to go about reducing some of those disparities. One of the things that we found in our initial research, which again, is probably no surprise to all of you, is just, again, those state agencies really do define data differently, collect data differently, have different reporting requirements. So we don't really have a great sense across all of the different state agencies around who's getting served, because we define those demographics so differently across state agencies. But in some ways, more importantly, we don't know who's not getting served within our behavioral health system, because we just haven't been able to find a good way to collect that data, and because it's not standardized. So those are some of the things that we anticipate the Behavioral Health Administration will do. I think about the Behavioral Health Administration as kind of the owner of behavioral health problems across the state, and the owner of the solutions, right? So the Behavioral Health Administration is kind of like the buck stops here. We heard from a lot of people, especially when we were holding public testimonies during the Behavioral Health Task Force, Coloradans who said, I called CDHS or OBH sent me to HCPF sent me to the RAY sent me to a provider, and it just felt like a kind of hot potato game to them, and it was just super frustrating. So we want to make sure that the Behavioral Health Administration really is kind of the buck stops here when it comes to identifying the problems across the state. The BHA will also be responsible for making sure that those problems are resolved. It might not be resolving the problems itself. The BHA will be holding its stakeholders and its partners accountable to helping to solve those problems, depending on what the problem is and what's the best way to address it. But probably the one thing that I'll just share around the Behavioral Health Administration is that really trying to look at getting more focused on prevention, moving more upstream to really focus on how do we get ahead of some of these challenges so that people are not getting into a crisis before when they're just in initial need of services. So what are those prevention and intervention strategies that we can begin early on? We also heard a lot throughout the work of the Behavioral Health Task Force around the need to really address the whole person, right? So if you can address the behavioral health needs of somebody, but they don't have housing, they don't have food security, then they're not going to be able to thrive in their community. So we really are trying to make sure that we're taking a whole person approach and addressing all the needs that somebody has to have in order to thrive in their communities and be healthy, both emotionally and physically. And then, of course, really just looking at how do we make sure that we, the Behavioral Health Administration itself is diverse, inclusive, and equitable, both in its infrastructure and its framing, and of course, in how we're working with our partners and serving people across the state. So if there is one thing that you walk away with from today's presentation, what I would share that I would stress is that the Behavioral Health Administration is cross-payer. So what that means is that in our current system, we have the Office of Behavioral Health within the Department of Human Services that works mostly with people who are uninsured. We have Healthcare Policy and Financing, our Medicaid agency that of course is working with its Medicaid members. And we have the Division of Insurance that is working with the private insurance carriers. Up until this point, there has been some collaboration. There's been lots of conversations about how those agencies will work together. The Behavioral Health Administration will actually be a more deliberate, thoughtful, and intentional collaboration amongst those three agencies, as well as the other state agencies. But I really focus on Medicaid and the Division of Insurance and what is currently the Office of Behavioral Health, because this is a Behavioral Health Administration that will work across all of those different entities, all of those different funding sources, again, in a very thoughtful and collaborative manner. What I would also share is that Colorado, in this sense, is really the trailblazer. We have identified other kind of similar behavioral health administrations in other states, but nothing that is cross-payer. So this is really unique. It means that we're going to be kind of learning a little bit along the way, which is why we're taking just a phased approach to make sure that we get it right and that we don't try to rush and get it all done in year one, because it's going to take more than year one as well. All right, so let me talk a little bit about the governance model of the Behavioral Health Administration, because this is something that we spent a whole heck of a lot of time talking about. And we think about it, so it's kind of like a three-legged stool for the governance model. The first one being the Behavioral Health Commissioner. So this is going to be a cabinet level position, which is the first time that the state of Colorado will have a behavioral health position as a member of the governor's cabinet. It really, I think, speaks to how much of a priority this is for the Polis administration and how much we want it to continue to be a priority for future administrations. So that is a huge piece of the governance structure, to make sure that we have a commissioner who is part of the governor's cabinet and who's also working very closely with their peers in the cabinet to make sure that that collaboration and that alignment and partnership is in place, and that we are working together as much as possible. What I will share with everyone, in case you haven't heard, is that we are currently recruiting for the Behavioral Health Commissioner. This is a national search that is underway. You'll see the website for this work later on in the presentation. You can go to the website and see the commissioner job description. So definitely, if you think you have good candidates, or if you want to apply yourself, take a look at it. We have engaged a search firm to help us with this because it is a national search, but they're open to hearing nominations from people if you want to put names forward. And just, again, we're trying to leave no stone unturned so we can find the best person for this role. What I will say, just so everyone knows, is that the first round of candidates will be considered by having their application in by Thanksgiving. So definitely, just if you're interested or you know someone who might be a good fit, just move on that as soon as possible, because we're on a fast timeline. The goal is to hope that the commissioner at least will have been offered and accepted the position by early January 2022. I'm not sure that they'll be able to start in January 2022, but no later than February 2022 at this point. And then the last piece of the governance structure that I will share, that I'll talk about, is the Advisory Council. This is a council that will have no state people. It really will just be consistent of our stakeholders in the behavioral health system. So the Advisory Council will include people with lived experience, their family members, tribes, rural voices, local public elected officials. It just will have a very wide range of voices and diversity, again, in every sense of that definition, to make sure that we really do have the voice of our stakeholders present and at the table. The Advisory Council will be working closely with the commissioner and their staff to really, kind of share what's working across the state in terms of, what programs really seem to be hitting the mark that we want to try to scale, maybe what programs aren't working so much, or some of our strategies aren't working so well and we need to do a course correction. As emerging needs are coming about in different communities, that's a chance for the Advisory Council to raise that to the Behavioral Health Administration and just make sure that we are addressing some of those emerging needs. Also, as part of the Advisory Council, we anticipate that there will be kind of standing and ad hoc work groups, and those work groups will focus on different topics or populations, and then really report up to the Advisory Council, who will continue to share that feedback to the BHA Commissioner. Some of those work groups, again, I said standing and ad hoc. I would imagine that like a standing work group might be one that is focused on alignment and partnership with the criminal justice system. An ad hoc work group could be something like, if the BHA had existed when COVID emerged, I would imagine that we probably would have had a COVID ad hoc work group as part of the Advisory Council. So there's still a lot of details to work through there, but again, the stress that I would put on the Advisory Council is that it really is the voice of stakeholders, giving some of that, feedback to the Commissioner and the Behavioral Health Administration. We do think that the Behavioral Health Administration will be submitting a annual report to the General Assembly Part of what a section of that report will actually be from the advisory council itself, and that section can't be edited or touched by the BHA commissioner or any of the staff members of the BHA, because we really want to make sure that the advisory council has a chance to be like the voice of the public, and who's also kind of sharing in that report what they're observing throughout the work of the Behavioral Health Administration. So this is a really convoluted model. Slide here. I'm not going to go into too much detail here. But just a couple of things that I would point out is that, again, the commissioner will be a member of the governor's cabinet and report to the governor. Because the Behavioral Health Administration will be housed within the Department of Human Services, at least until November of 2024, the commissioner will also work closely with the executive director of Department of Human Services. So right now, of course, the commissioner will work closely with Director Barnes. And then because we want to make sure that there is such deliberate, intentional collaboration and alignment across all of our state agencies, we do plan to have staff who are specific staff liaisons who are working between the Behavioral Health Administration and the different state agencies. The level or how many liaisons will depend on kind of the level of behavioral health programs that those state agencies have. So for instance, of course, HCPOF is going to be a critical member of and partner with the Behavioral Health Administration. So we want to make sure that there is a HCPOF liaison and a BHA liaison who, is really making sure that the two agencies are aligned. For other state agencies, like perhaps the Department of Agriculture and Department of Higher Ed, which have some behavioral health programs, but much less of a focus, we might have one liaison who's working with a couple of different agencies who, again, is just making sure that that alignment and coordination is happening. So that really is just to make sure that that we're trying to be really thoughtful about how do we make sure that that coordination and alignment is happening, and part of that will be kind of the dedicated staff resources that we are intending to have. So just to go over again the timeline. So we submitted our plan on November 1st, just a few weeks ago, on the phased approach to establish the BHA. It will be up and running by July 1st, 2022, but only partially functional. And then, as I said, it will be housed within the Department of Human Services until November 2024, at which point we will make a recommendation around what should be the permanent home for the Behavioral Health Administration. Does it make sense to continue to keep it in the Department of Human Services? The other obvious state agency would be HCPOF, but I think that's something that we will begin to evaluate and kind of consider the different options later on, closer to 2024, once we have the BHA up and running, because I think we can probably all agree that there's going to be a lot that we learn as we get the BHA up and running and as things continue to change. So just to kind of quickly go over the proposed work of the BHA, this again is a very busy slide. One of the things that the Behavioral Health Task Force did back in the summer of 2020 was identify these 6 pillars that you see here on your screen, starting with access, affordability, workforce and support, et cetera, that really all of the 150 recommendations fell under one of these 6 pillars. And the task force said we need to make sure that we addressed all the needs underneath these 6 pillars, because that's what we need to have in place in Colorado in order for us to have a strong foundation for our behavioral health system. So you'll see different things on here. If I start with workforce and support, we are hearing a lot these days about how dire the workforce shortage is in the behavioral health field. So we anticipate and envision that the Behavioral Health Administration will really kind of rein in all of those different strategies and initiatives, and again, make sure that they are aligned, that we're complementing each other, that if there's duplication, that we're addressing that. And again, trying to think through what are some things that we need to do in the long term to address the workforce shortage, and what are the things that we need to do in the very short term to address the workforce shortage. I will also share accountability is another pillar. I would say if I think about all of the stakeholder feedback that we heard from January of this year through October, the two biggest words that we heard more than anything else was accountability and transparency. So looking at the data interoperability, setting standards across our behavioral health system, and making sure that we have a kind of public-facing dashboard that's sharing the progress that we're making in reforming our behavioral health system, as well as the progress or how different partners and stakeholders are achieving those standards. We also anticipate that we'll have a master contract across all of the state agencies. And again, this comes back to how all of the different state agencies right now collect and report data, or have defined, collect, report data differently. So how do we put some of that standardization in place across all of the state agencies so that we are all asking for data in the same way, defining it in the same way, making sure that we're asking the same thing of all of our providers and partners so that they're not trying to keep up with all of these different expectations across different state agencies. Local and consumer guidance, I talked about how much we heard that we really need to make sure that we have the voice of people with lived experience, helping us to design and reform the system. Of course, we also heard a lot about just how different the needs are in rural and frontier communities as opposed to what we have and what we see here on the Front Range. So again, just making sure that we're being really thoughtful about local voice and consumer voices as well. Capacity and policy development under whole person care. This is where we will start to see addressing some of the social determinants of health. Really, a lot of that we expect will be done through care coordination, which we have received some initial funding to get that off the ground, which is also a big priority that came out of the Behavioral Health Task Force. Really looking at how do we make sure that providers across the state are getting the technical assistance that they need. And again, where we're looking at where's that data interoperability that we can explore further. In the access piece, we do believe that there will be kind of care navigation that will be built within the Behavioral Health Administration in future years. Again, it's gonna take us a while to get there. Interestingly enough, one of the biggest things that we heard from Coloradans during the time that the task force was meeting was really about having a grievance and appeals process for the entire behavioral health system. So that's something that we're actually going to start working on in January of 2022 to say, we know that healthcare policy and financing, they have their own appeals, grievance and appeals process. The Division of Insurance and its private insurance carriers have their own grievance and appeals process. So part of the BHA, part of the work in 2022, we'll be looking at what's the data that we can pull from those sister agencies that are already collecting some of that grievance and appeals data. What can be shared with the BHA, and then what does the grievance and appeals process for the BHA look like across the system, so that we can really identify where there are patterns of problems, if you will, across the state. So we're going to actually put together a work group in early 2022 to help us kind of look at that more closely. The work group will be more than 50% people with lived experience or their loved ones, again, just to make sure that we're being really thoughtful about having that consumer voice help us design the grievance and appeals process. So we're being thoughtful about making sure that it works for the people who might need to use it. And then, affordability, again, really looking at, we've heard a lot around reimbursement rates and different reimbursement rates. And so we anticipate that the Behavioral Health Administration will be doing a lot of rate analysis across all payers, perhaps making some recommendations around that. We also want the BHA to be kind of like the legislative think tank, if you will. So right now, we have a legislature who is very, very focused on behavioral health, which is great. What we want the BHA to be is kind of like the one-stop place for legislators to go when they have an idea or a proposal that they want to consider or talk through. And so that way we are, again, kind of coordinating across all of the different state agencies and partners in the judicial branch to make sure that we're just being really thoughtful about it. And so I know one of the big questions from this group is, what does this mean for data and data interoperability? So everybody, I think, knows already in this group that we collect a whole heck of a lot of data here in Colorado. What we want the BHA to do is kind of take a step back and do two things. One is, kind of identify what's the data that we have to collect because of our federal funding sources or federal regulations. We know that there's really not any wiggle room there. So we're going to have to collect that information. But then we want the BHA to take a step back too and say, what's the data that we need to collect in order to know that our behavioral health system is working in Colorado, that it's functional, and then it's high quality. And that could be very different than the data that we're collecting today. So it's not going to be something that would be in addition to what data we're collecting today. What we want to do is say, let's collect the data that we're required to by the feds, and then let's collect the data that's going to tell us if we have a functioning, high-quality behavioral health system, and let's standardize that and do that across all of the different state agencies in Colorado. So that's one step of where we're trying to go. We want to make sure that we do have an integrated data system for behavioral health. We've got some initial thoughts around what that interoperability will look like. We certainly are far from making any decisions, but I know that there are conversations underway to kind of explore that further. Also looking at where are the existing systems that we can build off of. So for instance, HCPF has a very robust kind of data infrastructure already. One of the things that the BHA will be doing is actually leveraging HCPF's system, their MMIS system. And that is something that we've already received funding for, and we've started some of that initial planning, and probably that will be 100% functional. I think the plan is by July of 2023, and that's the first step. Eventually, the idea, or at least right now, is that we want to expand that kind of data infrastructure to all of the different state agencies that we're all using that data infrastructure. It's going to take us a while to get there, but the more that I think that we can align our different systems, I think the better off we'll all be. But I will definitely be interested in hearing everybody's thoughts around that. And then, yeah, so I think I said already, this is going to continue to evolve. I think that's probably why you've heard me say a lot. We envision, this is what we anticipate. Again, just knowing that things might change throughout the rest of the planning process and as we get the BHA up and running. So just in terms of immediate next steps, as I said, the governor has launched a national search to identify the commissioner for the Behavioral Health Administration. We are going to continue to kind of engage in these types of conversations, hear questions from all of you, hear your thoughts and suggestions so that we can incorporate that into our work plan. We do anticipate that there will be legislation in 2022 for the Behavioral Health Administration. It will be partially operational by July 1st, 2022. We want to continue to make sure that we're communicating about it and sharing what's happening, how things are progressing, and what the BHA is actually doing. And then that cross-agency collaboration is key, as well as continuing to go back to the recommendations that came out of the Behavioral Health Task Force and continually reassessing what's our environment that we're in right now, what are some of the priorities that we should be implementing sooner rather than later based on 150 recommendations, and really continuing just to go back to that blueprint for reform, kind of as our guide, if you will, for the coming years, to make sure that we are really considering all those different recommendations, prioritizing them, and then implementing them. So I mentioned earlier around our webpage. This is the link to our webpage. Definitely would encourage you to keep an eye on that. We update it around once a week to include, anything that's new, any new meetings that are coming up, things that are happening. There's an opportunity for people to submit questions or make suggestions, whether you want to give your name or do it anonymously. You can do either, but we do check those on a weekly basis and then update our frequently asked questions page to make sure that we're sharing the latest information with everybody. So I would definitely just encourage you to bookmark that and keep an eye on it. So happy to go into questions and answers. I know that was a whole heck of a lot of information. I tried not to talk too fast, but I'm sure it was a little fast. And I'll check the chat box real quickly for questions. So it's from Shelley. I feel like we need a point of view of what is needed for the people out there rather than us. Totally agree with you, Shelley, and I think that's why we're trying to be really thoughtful around how can we continue to have people with lived experience and their family members, as well as providers, right? I mean, we need
Absolutely.
to get really a holistic
Summer,
view.
just so you know, I put that on there when you had the 4 data points, and then after I said it, I realized that, this is just a very big overview and high level, and it's probably not necessarily the right place to say that. So I just wanted to let you know where my mind was going was, you know, when I hear, it's just me, you know what I mean? It's just me. But when I hear like, we need to get all the data from the people that's exactly the same. Well, I also think from an equity lens, we want to look at what does this or that population, or what does this type of provider need for them to do their job well? Like, it just,
Yeah.
it seems like it was very much from a, like an executive point of view, you know, and I get wanting to consolidate. I totally do. So on one hand, I think it's premature for me to comment. On the other hand, that's where I was thinking, you know what I mean? So just so you know.
Yeah, no, that totally makes sense. And I think you're right, Shelley. I mean, it's just, you know, well, first of all, I could probably talk for 3 hours around some of the details of the BHA. So this is more of a higher level overview, but those are exactly the types of things that we need to be thinking about as we start to plan for the implementation. So I also appreciate you raising that. So I see another question here from Aaron. Will there be other staff positions hired aside from the BHA administrator, or just staffed with existing positions and existing agencies? Great question, Aaron. So it's actually, we will be hiring additional staff for the Behavioral Health Administration outside of just the commissioner. So this current year, we are starting to begin, this current fiscal year, we're starting to begin hiring some support positions just to help us build kind of the backbone for the BHA. So looking at how do we get some accounting folks in place, HR folks in place, communications, just again, some of those just initial support functions. We have about, I think, 20 to 25 positions that we're going to be hiring for in next fiscal year, assuming that the budget is approved. And those will start to be some of the leadership positions for different teams or different team positions. Again, we've got some ideas right now of the teams that could be part of the BHA, but we do think that when the commissioner is going to come on board, that person is probably going to want to kind of assess all the work that we've done and make their own thoughts and opinions around what is the best structure for the BHA. But ultimately, we think to be successful, we will probably be hiring by 2024, from now to 2024, about 70 new positions for the Behavioral Health Administration. And I'll just share a little bit around, you know, I shared that kind of pillar slide with some of the different functions that were highlighted that the BHA will be doing. Some of that work is already being done by community behavioral health within the Office of Behavioral Health. So most of CBH will be actually moving over to the Behavioral Health Administration, and the BHA will be able to kind of leverage that existing kind of knowledge and expertise that we already have to make sure that we can start to meet some of the functions of the BHA. The reason that we need more staff for the BHA is one, that the BHA is expected to have or to be doing a lot more functions than what's currently being done within community behavioral health or any of the other partners or agencies across the state. And because the BHA is cross-payer, we're taking a much broader view, and again, trying to be really thoughtful about how do we align and coordinate across payer and make sure that we're being effective and efficient as possible. Let's see, so a question from Jessica. Could you speak to how you anticipate this will impact the MSO system? That's a great question, Jessica, and I don't think we have an answer for that right now. I think that will be part of the conversation that will take place when the BHA finally gets up and running. I don't think it's going to be anything that we're going to have conversations about in the next couple of months. You know, I think if I were to guess, and again, this is ever changing, I would say maybe in the summer of 2022, we might start saying, okay, so what does this look like for our MSOs, for our ASOs, for all of our different partners? And I think that will probably be a broader conversation that we'll be having with lots of different stakeholders to make sure that we're thinking about this the right way. Other questions? You can feel free to unmute yourself as well and jump in.
I just posted, but I can tell you the question.
Sure, go ahead.
Yeah, thanks so much for the initiative. It's great that it's going to be a streamlining of data collection across sites and across what we collect. We are starting a new project for the math expansion in rural sites, and redefining some of the data collection. And I would like to understand what is the timeline that you are proposing, and what would be the best way for us to align with what is already collected by you guys, so we don't have so many inconsistencies down the line.
That's a great question. And I would imagine that we will probably have some kind of data work group that's probably launched sometime in 2022. Again, we're trying to resist making too many decisions right now, because we want the commissioner to come on board and be able to make their own decisions and really lead in the direction that they think is best. But I would imagine that we'll have some kind of work group, or that we'll be coming back to groups like this and saying, here's what we're thinking, tell us what we're missing, tell us what other projects we should be considering, and so forth. So I think those conversations will continue for sure. I say we might have a work group. I know that we also are trying to be thoughtful around if there's groups that are already meeting, again, such as this one, that we could just go to and tap into and say, hey, can we participate in these meetings, once a month, and just, check in for 15 minutes and tell you where we are and get your feedback. Or I don't know, there's different ways I think that we can approach it, but we do want to make sure that we're being thoughtful about the ongoing work and not asking everyone to duplicate meetings and conversations. What I would say is that if you go to that webpage, is that, again, we keep kind of all of our meetings updated on there. We did receive some funding in the 2021 session to begin to think about and design a care coordination interface, which would really be kind of like a web page that would begin to kind of give people an opportunity to say, if you're looking for behavioral health services or other services to meet your whole person needs, this care coordination kind of interface will be that first step. There is a kind of technology group as part of that work that hasn't kicked off yet. We're waiting for procurement to approve the contracts and so forth. But I think the members for those groups have already been selected. However, they are open to the public, just like all of the other groups that we've had throughout this work. And generally, people from the public are able to kind of join in the conversations just as anybody else would. I think the difference is they probably just won't be able to vote. But I think there could be a good opportunity there to maybe have one or two of you listen in and to that technology work group, and kind of share feedback with this group as well, just to make sure that there's alignment and knowledge of the different pieces that are happening. Okay, so I see a question. Any thoughts on the relationship and the alignment between the future BHA and the opioid settlement funds in Colorado from our Attorney General? So we, of course, have had some very initial conversations. How that might align or come together, I'm not sure that we have a good sense of that yet. And I think because the BHA isn't up and running yet, we're trying not to get too much ahead of ourselves in terms of reaching out to the AG's office and saying like, hey, let's think about what this could look like. And we're also trying to be thoughtful of that too. So we're all both aware of our different initiatives. We just haven't quite figured out yet how they're going to align, especially since the opioid settlement funds will really be locally driven much more than driven by the state.
And
Any
Summer,
other
I
questions?
saw there was
Yeah.
one other question in the chat from Allison that I wanted to make sure we touched on, which Allison said, I know the BHA was originally supposed to be an authority as opposed to an administration. Was this move just a name change, or does it reflect a different leadership model?
Great question. I'm sorry I missed that. It's actually really just a name change. When we were, we did from the very beginning, when we came up with the concept, talk about it as a behavioral health authority. And then we just received feedback from a number of different stakeholders before we even voted within the task force to move forward with the BHA. We heard from a lot of different stakeholders who said that the word authority just really did not resonate with them, that actually they had a visceral reaction to it. And I would say, those were from we heard that feedback from providers. We heard that from our lieutenant governor. We heard that from some of our other partners who just said, ugh, authority doesn't feel very friendly. And so that it was actually just the reason for the name change to the administration. And thank you for raising that, because we really are working hard to make sure that everybody is calling it a behavioral health administration. Every once in a while, I'll still hear somebody say authority, and I'm like, it's administration, just so we're all being consistent on our messaging.
Are there any other questions for Summer, comments? It doesn't seem like anybody has anything else. So Summer, I just wanted to say a huge thank you. I think I can speak for everybody here in safely saying, like, I learned a ton from your presentation. This was really helpful in kind of orienting me to what's going on. And it was just really great to hear kind of a direct line from you, rather than trying to piece together all of the different press releases and everything else that's come out. So thank you so much again. This was really great. And to everybody here, thank you so much for attending, and we look forward to seeing everybody in the new year. Have a happy holiday season.
Thanks, everybody. Thanks for having me.